Think forward. Think Research Channel.
Well, thank you for all coming tonight. I hope I can give you guys some tips on the aging foot. We can't really slow down the aging process, that's inevitable, but hopefully I can give you some tips to keep your quality of life a little bit better. The two things that I've noticed when I was researching to do this lecture were arthritis and obesity, and those are two things that go hand in hand with our aging foot. If you can keep an ideal body weight, that really can slow down the destruction of your foot and preserve their joints. So being active can really help, make sure you have an ideal body weight. So they're really connected, and as we've seen, obesity seems to be in the headlines every day about the health impact on that. And I see so many patients daily that are overweight that it really contributes to their foot pain. And our joints need activity to keep them healthy. The synovial fluid needs to run through our joints, and it can only do that if we're active, and that brings the nutrients to the joints to keep them healthy. So it's really important that we try to maintain an ideal body weight and to remain active. So those are things that I'm passionate about, exercise, and I just think that we can all do that to keep our general health better. So here's some foot facts. The foot contains 26 bones, 28 actually if you include the sesamoid bones, where there are these little two bean-shaped bones underneath the ball of your foot, 107 ligaments, 19 muscles. Basically, there's a quarter of our bones are in our feet, and our feet are our foundation for everything. So they're really important. And they're very much abused, and it's amazing. The average person, can run, 10,000 steps a day, which adds up to, 115,000 miles. That's actually I believe 4 times around the globe in a lifetime that we actually walk. So it's pretty impressive. Women have 4 times as many foot problems as men, and I do think that's definitely related to shoes. Shoes are the demise for a lot of people's feet. I see so many problems related to shoes, and I think that it's really overlooked. In my other lecture on the runner's foot, I talked about how it's so important to replace your shoes often, and most runners know that after 200 to 400 miles to replace their shoes, but I find the older folks that I see don't tend to replace their shoes as much, and they come into my office and their shoes are just not in the greatest condition, and that's just such a simple thing to do, to replace or alternate your shoes more often than you think. And your feet, they definitely mirror your whole general health. Again, so many problems initially show up in your feet. Nerve problems. Neuromas are basically inflammation of a nerve. The nerve actually develops scar tissue around the nerve, and it can be a very painful scenario. It's basically foot pain in the ball of your foot. It can lead to numbness and tingling and burning in the foot. There's been some other advances on the treatment of that. I typically inject that with an alcohol solution to kill the nerve. Because once the nerve develops a bunch of scar tissue like that, it's basically a big wad of scar tissue around a non-functioning nerve. And in the surgery, what we do is we go in there and we remove the nerve. But to avoid surgery, you can inject these series of alcohol injections. It's a sclerosing agent, and it kills the nerve or basically puts it to sleep. And I'd say it's about 75% effective. Circulation problems, like in diabetes, I see so many people that come in and have numb feet or burning feet, and I ask them, are you diabetic? Well, I don't know. No, I'm not. And I've seen so many people 2 years before their actual blood sugar was higher that they had these subtle signs of diabetes, and they had a strong family history. And so definitely your feet mirror your general health. So what happens in the feet when we age? Well, like anything, you lose elasticity. Your skin is not as strong, it's not as tense. The laxity of the ligaments, they stretch out, they're not as tight. You get atrophy of the adipose or fat tissue in the sole of your feet, so you have more bony prominences, you have less padding. So you feel the bones when you walk more. And it's really not, you're not losing your mind. You do have less padding down there. And so, and as well, the cartilage degenerates. And all these things lead to foot pain. The small muscles of your foot, they are really important in preventing the formations of hammer toes and other deformities like hallux valgus or bunions. And they tend to atrophy as well, and that leads to buckling of the joints. The toe starts to buckle and becomes bent, and then that leads to bony prominences, bunions, and problems in shoes. Again, osteoporosis, that's a thing that we can't really prevent all the way. We can prevent it by having a good diet, and definitely weight-bearing exercise has shown that can slow down the progression of that, but it is a part of the aging process. And again, I get back to this common theme of being active. I think if we are active, we don't lose as much muscle, we don't lose as much balance or your sense of proprioception, that sense of balance and range of motion in our joints if we are active. It's just so connected. Being active and keeping our weight down is just so essential to our general health, and in the foot, it's the same. Oftentimes people come in and they say, well, I'm a size 10B, and I can tell their shoes are not fitting appropriately. They have these huge sores on their feet, they're getting black toenails, they're getting these huge calluses, and they're trying to shove their feet in these little shoes. And it's a fact that your foot size does increase. Your arch height decreases, the joints start to break down, the ligaments become less tight, and that leads to a widening, elongated foot. It doesn't grow, it just breaks down. And so, again, it's really important to get your foot measured, I think once a year. And when you buy shoes, it's good to buy them in the evening or in the afternoon or even after you exercise, because then they're going to be at their biggest size. This is my 8-year-old's foot. So you can see it's got a nice arch, the nice tone, nice skin color, so forth. This is a 43-year-old woman's foot, my wife's foot. Again, it's you can see she's got an arch, she's got a little bunion, but nothing too bad. The skin looks good, she's got good tone, not too many problems there. And then this is a foot of an 83-year-old woman. So you can just see the loss of the arch. The arch height is decreased, the edema in the ankle, the skin. You can't really see the supple, tight elasticness of the feet that I just showed you. Also, the nails are a little bit thicker. And if you can look really closely, you don't see a lot of hair growth and so forth. And all those things are what happens as the foot ages. The foot becomes dry. It loses the elasticity. The dryness isn't just, it's part of the aging process, but oftentimes the dryness is from being dehydrated. And I see a lot of folks that are on diuretics, and they drink coffee and tea and sodas and so forth, and all those are diuretics that cause dehydration, but I don't find that the older population drinks enough fluid or water, and I think that is such an important thing to keep our tissue hydrated and our tissue healthy. One of the things that can happen if you have dry skin is your skin is the first barrier to infection. And so it's the largest organ in our body, and if our skin is healthy, it prevents other little infections like athlete's foot fungus. If you have athlete's foot fungus, that can lead to warts, which are viral infections, and it all is really connected. This is just another slide to show the back view of the feet. As we age, our feet lose the arch height, and our arch height collapses in. What I do when I look at somebody's feet to assess them for an appropriate shoe or possibly an insert or an orthotic is I basically bisect the calf muscle and the bisection of the heel. And in the perfect scenario, that should be a straight line perpendicular to the weight-bearing surface. If you can look at visually the heel bisection of this patient, it would be at an angle as her left foot is significantly more pronated. And pronation is basically a word that we use to describe the flattening of an arch. And when you have flatter feet or pronated feet, that's an unstable foot. It's hypermobile, so it moves around a lot. So basically, in a nutshell, your feet have to work harder than they should. So that translates up the chain. So your leg muscles have to work harder. And I see this in a lot of runners that have flatter feet. Their feet are inefficient and they move around too much, and that leads to shin and leg pain. And so one of the simplest things to do is to get better supportive shoes. So what happens into our skin? Dermatological changes. Onychomycosis, a fancy word for fungal infections. Now, I see a lot of patients for thick toenails, and they think that's just, well, my nails are thick because I'm getting older. Well, that's really not the case. It's actually from a fungus infection or trauma. So those are the two conditions, because basically your toenails should mirror your fingernails. They should be about the same diameter. But in your feet, you know, they're traumatized in shoes and activities and so forth, and so that can lead to a fungal infection. So say you stubbed your toe, your toenail turned black, it fell off. When it was growing back in, that could have led to a fungal infection. If you had athlete's foot on your foot, it got into your toenail and your toenail became thickened. Toenail fungus isn't the end of the world. It's going to make your nails thicker, harder to cut, but they can lead to foot pain. So if your nails are an inch thick, they're not going to fit into your Ferragamo shoes. So if you have a thinner diameter nail, it's definitely going to be more comfortable. The other thing that can happen is we could get calluses. Calluses happen through bony prominences. So if you get hammer toes or bunions, or as I was saying earlier, if your fat pad starts to atrophy, your metatarsal bones, the bones of the ball of your foot, become more prominent, and so your body tries to protect that, so that it builds up callus. And that callus can lead to really painful lesions under the ball of your foot or even on the top of your toes. Xerosis, that's just a fancy word for dry skin. Often, though, dry skin is related to being dehydrated, like I was saying before. It also is common in people that have fungal infections or athlete's foot fungus. I see a lot of people that have a very dry, scaly foot. It doesn't have to itch, but that is definitely tinea pedis or athlete's foot fungus. And that, again, their skin is our first barrier to infection. And so I've seen other problems related to just common athlete's foot fungus. People can get a super infection, a bacterial infection from that, especially between their toes. If the toes are really wet and whitish and what we call being macerated, that can lead to a bacterial infection. And I've seen a lot of bad infections over the years, especially in diabetics, for that. So it's really important to keep hydrated and to moisturize our skin. Ulcers, those are local areas of tissue destruction. Their most common forms are stasis ulcers or diabetic ulcers. So stasis ulcers are related to the circulation in our extremities, commonly in the ankle. Basically, the veins and lymphatic systems don't pump the blood back up as well, back up the legs, and it pools in the ankle bones. And that leads to breakdown of the skin, and it basically can weep and ulcerate and be very difficult to heal. So the common thing in diabetics are these diabetic foot ulcers. And in diabetics, again, most diabetics, if they've had the disease a long time, they have a certain form of peripheral neuropathy. So basically, they don't have the feeling in their feet that they normally would. So if they were to step on something or have a rock in their shoe, or let's just say they wore a tight shoe and they didn't notice a callus forming or a blister forming, it can be so simple as a blister that leads to an ulcer, and then it can be a big problem. I've seen so many patients that had a blister on their toe that I've had to go on and amputate the toe because it didn't heal. And in diabetics, the two biggest problems are their circulation. The vessels in the toes and the extremities are not so great, and then there's their nerve sensation. They do not notice a problem until it's a big problem. So fissures are another thing I see a lot of. Those are cracks in the skin, and I see this in young and old people, but basically what happens is, more commonly around the heel, a weight-bearing portion of your foot, it develops callus, and it's common in people that wear a lot of sandals and clogs and open or backless shoes. I think the skin really dries out, especially in the summer and in the winter too. But in the summer, if you're in a pool and you're in chlorine and you're wearing a lot of sandals, the callus can build up because the shoe isn't providing enough support, so your body builds up callus. That subsequently dries out and it cracks, and it can lead to a very painful, basically a cut. So it's really important to try to keep our skin moisturized, and if you do have calluses, a common thing, you can just use an emery board or a pumice stone and use that on a regular basis, and in a moisturizing cream. That can solve a lot of problems. This is a classic picture of onychomycosis, or toenail fungus. Now, this woman has a fairly severe infection. All her nails are significantly thickened. You can also see on her little toe, in between her fourth and fifth toe, this red patch, macerated, red, scaly, peely skin, and it's a classic scenario, athlete's foot and onychomycosis. Now these, as you can tell, would be pretty difficult to manage on your own. I mean, you'd have to have the industrial strength clippers to get through these things. So in my practice, I see patients for this problem. It can be treated with an oral agent, but I've found in this population, they're on so many different medicines, it's not really a very good option for them, because the oral antifungal medicine can be hard on the liver, and if they have diabetes or other problems and they're on a lot of medicines, it's just another thing that they have to take, and it's really not going to impact their life too greatly if it's maintained. So this obviously wasn't maintained, but I have people come in every few months and have these nails debrided. You have to actually use a Dremel tool to file them down because they're so thick. But they can lead to a lot of discomfort. You can tell how thick they are, and if they're long, people end up walking on the end of their nails, and it can be really uncomfortable. Now, this next slide, I want to warn you, this lady came in about 2 months ago, and she was an older woman, and her daughter brought her in, and it's a pretty severe case of onychomycosis. So there it is. Now, this woman could not wear shoes. She came in my office wearing slippers because those nails would not allow her to wear something like that. This is an extreme case, but this is what can happen. I want you to look at the skin. Look at the skin. Look at how dry her skin is. Look at the edema in her toes are like little sausages. They're very edematous. She hadn't been to the doctor in 3 or 4 years. She was in generally pretty good health, but she just wasn't maintained. She didn't have very good foot maintenance, and this can be a big problem. So for fungal infections, I do treat that, and one of the things I like to do is I pulse it with this terbinafine. I like to pulse it because I found that it's a good way to treat it without a lot of the hepatic side effects, and it's been proven to be fairly effective this way. So what I do is I have you take the medicine. It's a 250 milligram tablet. You take it once a day for a week, and then off 3 weeks, and then you repeat that 3 more times. The classic way to prescribe for onychomycosis would be daily for 90 days. It takes about 9 to 12 months for your nails to grow out. So it's pretty slow process. But with the pulse dosing, I've had patients that are on a lot of medicines that can still get the benefit of this and have better looking toenails. The other thing I stress with this is you will not get a very good result unless you do topical antifungal therapy. I tell everybody that I treat for onychomycosis, it's not even worth doing it if you're not willing to do the topicals. Now, there's an easy topical that you can use, Lamisil AT gel. It's a gel, so you can use it between your toes where the fungus hangs out. Also, I tell people to put it around the toenail or even on the toenail because the fungus has to get in on the skin to get into the toenail. So if you can keep the fungus off your skin, theoretically you should be able to keep it out of your toenail. But even with all that, I'd say the success rate of treating onychomycosis is probably only in the 70% range, just because it's a mixed infection. It's not just dermatophytes or fungus. It's mold, it's yeast, and we don't have medicine to kill all those organisms, but they have a symbiotic relationship. They cling on to the dermatophyte, and so if you can kill the dermatophyte, oftentimes you can get a pretty good result with terbinafine. So other things, debridements for calluses, pads, I do a lot of this. You can do this yourself with a pumice stone or emery board, but calluses are very painful, especially on the ball of the foot as the tissue atrophies. But there's some simple things that you can do with metatarsal pads. I have those, and I put those behind the metatarsal heads, so it's basically almost in the arch, and that off-weights the metatarsals and really can help with the callus pain. Topical keratolytics, those are basically creams that break down the stratum cornea, which is the outer layer of the epidermis that builds up. Urea is one of the creams that's available over the counter that's a great keratolytic, and it's a great moisturizer. There's a cream that's over the counter called Kerasal. It's Kerasal, and it's a good keratolytic moisturizing cream that I often recommend. Sometimes surgery is necessary to remove the ingrown toenail, or if they have a bony prominence. Classically, this is on the little toe where they get a really thick callus and they're not able to wear shoes comfortably. It's a pretty simple procedure where we make a small incision and remove that bony prominence, and it doesn't take a lot of downtime. And again, the shoes. Shoes are so important. I know I probably spend too much time on shoes. I like to keep things simple, but I just see so many problems related to shoes and the wrong shoe for the wrong foot. Musculoskeletal conditions. So these, again, are all pretty common. The first one, hallux valgus or bunion. You don't really develop a bunion from shoes. That's a misnomer. You inherit that condition from your parents. Basically, you inherit all the good and the bad from your parents. diabetes, high blood pressure, the propensity to develop arthritis, all those things. But the hallux valgus, it can really become painful if that bunion isn't accommodated. So getting a wide, comfortable shoe is the first thing I always tell somebody. Hammer toes. Those are a buckling of the toe. The toe starts to bend. It can bend you have two joints in your toe, just like your finger. So it can bend at the first joint here, or it can bend at this joint. It could be a claw toe, it could be a hammer toe, it could be a mallet toe. So it could bend at the end like a mallet. So all those conditions can lead to calluses on the top of the toes, and that can lead to a painful condition. Again, shoes that have a high toe box can accommodate those problems. Hallux rigidus. This is the most common form of arthritis in the foot. It's in the big toe joint, the first metatarsal phalangeal joint, and it's a narrowing of the joint. The joint starts to narrow. The joint becomes arthritic. The cartilage starts to erode, and you develop all these osteophytes or bone spurs on the top and on the sides of the joint. That can be very painful because this is the main joint we use with propulsion. It's the joint that we push off with every step. You should have about 60 degrees of dorsiflexion in this joint for a normal gait. If you don't have adequate dorsiflexion in your joint, you will have pain. Or you will compensate that gait. You will walk on the side of the foot, leading to other problems. I often see people walking on the side of their foot, and they come in, well, my side of the foot hurts, but my big toe joint hurts too. And that's because of the compensation they're using. They're supinating their foot. They're walking on the side of their foot, and that's causing the tendons on the side of the foot to get overtaxed. And because they don't have the range of motion in that joint for a normal gait. The posterior tibialis dysfunction, again, this is a real common problem I see in the elderly. The tendons start to weaken. The posterior tibial tendon is the main inverter of the arch. It really supports the arch, and that tends to atrophy, it attenuates, it loosens up, and when that happens, the arch starts to collapse and it flattens out, leading to a flat foot deformity. And this can be a very painful scenario because the foot collapses in, it pronates, it becomes very unstable, and that leads to a lot of foot, leg pain up the chain. So it's a pretty significant problem. Achilles tendonitis, plantar fasciitis, I see this a lot as well. As you get older, you're less flexible. The tissue doesn't repair itself as fast. When you get injured, it takes longer to get better. I know this myself. I've been having calf pulls lately, and I used to be able to run without a problem. And now I have to do all these exercises to keep things from breaking down and stretching and all that. But it's important. I think there's a lot of emphasis on aerobic walking exercise. That's great, but I think that we need to also look at other things to keep us moving. Our joints really need a lot of flexibility and strength training as well, and strength training is really important. Yoga, Pilates, Tai Chi, all these things are really helpful that you can all do to improve your mobility. And I think if we were to really look at that and do more flexibility after we exercise, a lot of these overuse injuries like plantar fasciitis and Achilles tendonitis wouldn't be as common. So this is a picture of hammer toes. You can see the toes, the second and third toes. Actually, all her toes are fairly contracted at that proximal, that first joint. This is obviously non-weight bearing. She's not standing, but if she were to stand, the toe still would not flatten out. And what this leads to is that there's redness and pain on the top of those joints because they stick so far up in her shoes. The other thing that happens is the metatarsal becomes plantar flex. So if you bend your finger back, your metacarpal bone will plantar flex, and that makes the callus or the ball of your foot more prominent, and that can lead to calluses and pain. So this is a fairly simple procedure to fix. What we do typically for this is we fuse the joint. We remove the cartilage on the sides of the bone, and classically what I'll do is what's called a peg and hole fusion. I will make a peg out of one of the bones and a corresponding hole, and then I will drive a K-wire or a wire through the toe, shish kebabbing the toe, if you will, to straighten it. And that will, the downside of that is it's not going to bend at that joint. But it doesn't really bend now anyway. It's fused basically in that position. And if you were to fuse it straight, then it's going to be a more functional toe. This is an example of a bunion. You can see the toe moving over in what we call valgus. The big toe is touching or abutting the second toe. You can see the second, third, and fourth toe are all contracting. They're buckling. And that, especially look at the third toe. If you're walking on that toenail, that is not a comfortable scenario. And oftentimes I'll see patients that have a really thick, painful callus at the end of their toe, and their nail will subsequently be thick. And that's because of the constant trauma to the nail. The nail gets irritated. Either a fungus develops in that, or the nail plate or matrix becomes damaged, and the nail gets very thick, and it's painful. This is an example of an adult acquired flat foot. Look at that arch. She's basically walking on her ankle bone there. That is a very classic case of posterior tibialis dysfunction. The posterior tibialis tendon comes down the ankle bone and inserts into the arch of the foot. It's the main supporter of the arch, and she does not recall an injury or anything like that, but she said that it just over time her arch started to collapse in. And I saw her initially for this a few years back, and it was pretty uncomfortable, and I put her in an insert and a more supportive shoe, and it definitely helped. But it definitely can lead to loss of mobility and a lot of discomfort. So when if this does happen and the patient is an active person, it's a fairly involved surgery, but what we could do is we could do you can do a tendon transfer where you actually transfer one of the tendons next to the posterior tibialis tendon, and you insert it or graft it into that area. In this scenario, you'd have to do other work, maybe some bone work as well, but it's a pretty good procedure for patients that have like a tear in their posterior tibial tendon, because it can lead to a really collapsed arch. So what do you do for all these problems? Well, if you tried wider shoes and that didn't help, then, well, you got to go to the next level. I tell people when they come to see me, if their bunion hurts, I say, well, if it's impacting your quality of life, I think then you need to have that fixed. If you're sacrificing your lifestyle, if you don't want to go for a walk or a run or a hike or go out with your grandchildren or whatever because your feet will hurt, then that's not a good way to live your life. So I say if it's a quality of life issue. So because the surgery is a fairly simple, non-risk surgery. So the bunionectomy, basically what we're doing is we're trying to realign that joint. An osteotomy is basically a fancy word for cutting the bone. We're cutting the bone and we're moving it over to realign that joint. And after we do that, we often use some sort of fixation to hold it in place. So a screw, a plate, something, because you can't just cut it, move it over, and sew it back up. It has to be fixated so it doesn't move back into that malposition. a fusion like I talked about for the hammer toe. That straightens the toe for a hammer toe. An exostectomy, basically just removing a bony prominence that's causing pain. Sometimes people have a bunion, but their toe is straight, either on the top or the side, but they're having a lot of pain in their shoes. I had this lady that ran. She was 74 years old. She ran 4 to 5 miles a day, and she was getting a painful callus from her bunion. Her toe was straight, but she had a big bump on the side of her toe, and that led to a really painful callus. All I did was I shaved off the bump, and she was back running again. So it doesn't have to be a super involved procedure. A common thing I do for hallux rigidus, or the arthritis in the first metatarsophalangeal joint, is what we call a decompression osteotomy. You want to decompress that joint because the joint is jammed. So there's no motion there. So what we do is we take a wedge of the bone out of the metatarsal, essentially shortening that bone so that joint, the two bones, can move. And when we do that, we also shave off the top spurs and the sides and basically remodel that joint. If there's erosion in the cartilage, often what we do is we fenestrate or poke holes in the erosion of the cartilage, and what that does, it brings in fibrocartilage. It's not as good as the original hyaline cartilage that we're born with, but it's better than nothing. You can put an implant in the joint. Basically, that acts like a spacer. So if you go in there and the joint is really not in good condition, and what I mean by that is the cartilage is really eroded, oftentimes it's just one side of the joint that's damaged. The other side might be okay. And in that scenario, you can put a partial implant. So basically, you put a stem of titanium in that joint to act as a spacer where that cartilage was, and it's similar to what they do in hip replacements. If all else fails, you can fuse the joint. Fusion is not obviously the first option, but I think that it's a great procedure for people that have a lot of joint pain and they have cartilage that's gone, because the pain they're having from that joint is from their loss of cartilage. It's bone rubbing on bone. And usually at that point, they have pretty poor range of motion anyway. So if you fuse that joint, you're eliminating that painful motion and they're still functional. I've fused joints in people even under 60, and they have been very active and lead a pretty active life. So it's obviously not my first shot. I would not want to do that, but it's definitely something that can be done. So this is an example of hallux valgus or bunion. This person was older. You can kind of look at the x-ray and see that she's got osteoporosis. The bone doesn't really look super strong. It's got kind of a black appearance to it, especially in the distal toes. The two bones underneath the bunion, those are sesamoid bones. Everybody has those bones. They look like a cloud underneath that first metatarsal head. And this is after surgery. So what we did is I realigned the joint. You can see the toe is straighter now. And on this person, she was in her 80s. She had osteoporosis. Her bone was pretty soft. So I used a plate. And I usually just use a screw or two, but this actually I used a plate and 4 screws because the bone was soft. And that's another problem that you see. This particular lady had other health issues. I think she was on prednisone and so forth. So she had problems with that. But you need to be aware of those problems before you go in and operate on somebody. So that's why I used a bigger fixation unit, being the plate and the screws. But again, I think if you're active and you have a good body weight and you're in good condition because you're active, you can have surgery at this age and not be high risk. And this is an example of hallux rigidus. You can look at the joint. Compared to the other joints are nice and round. You can see the joint space there. The joint is square almost. There's a squaring of the whole joint. You can't really see a lot of joint space there because of all the arthritis there. This actually was someone in her 50s. I've seen it in all ages, but definitely after the fourth decade, I think, it's not like we're sent out to pasture, but that definitely is when a lot of problems begin. But this woman had a lot of pain. She was a walker. She just did not have the range of motion required for a normal gait. And so we went ahead and fixed that. This is a lateral view. You can see that spur on top there, how prominent it is. Now, can you imagine putting your foot like that into little pumps? I mean, I don't see how anybody could do that. But even a regular athletic shoe, she was having problems with that. So this is classic hallux rigidus. There's osteophytes or bone spurs all over on the top and the sides, and a loss of joint space. And so this is what I did. I did a decompression osteotomy. Basically, I shaved off all the bone spurs, and I took a wedge of bone from the metatarsal, and that screw goes on in an oblique way. I shortened that bone so she could move her toe. And there was a lot of cartilage erosion as well in there, and so I drilled some holes in her cartilage, and I have them do aggressive physical therapy right afterwards, because scar tissue is going to form. That's just a given after surgery. But if you can really try to mobilize the joint and move it and be active, she's done great. She's about 6 weeks now. This is an example of an implant. It's a titanium cap, basically. This woman had hallux rigidus. Again, she had osteoarthritis of that joint. And again, this is the main joint that becomes arthritic in the foot. What we did was we put this spacer in because her articular cartilage on her toe, the proximal phalanx, wasn't very bad. It's usually the metatarsal head that has a lot of the problem. And so we put that in there. We shaved off the spurs. It's not going to be, perfect, but it basically will give her a better range of motion and less grinding where it was bone on bone before. So this is an example of a fusion. And this woman was under 60. She had a couple of surgeries before. She had really bad arthritis in that joint, and we did what's called a chylectomy first, which just basically removing the bone spurs on that. Range of motion was better. Then we actually did another surgery where I made the bone cut, the decompression osteotomy, shortened the bone. And it just didn't give her enough range of motion, and she continued to have pain. Now, she's a power walker. She walks every day. She's had both of her joints fused, and it's not obviously the best thing for everybody, but it definitely can be done, and you can still lead a pretty active life. You can see that joint's been eliminated with that plate and those screws. So shoes. I'm really into shoes. I can't tell you how shoes play such a big role in foot pain. So I was talking about shoes with the high toe box. That means that they are high in the toe height. So SAS shoes, MBT shoes, it's M as in Mary, B as in boy, T as in Taylor. These are shoes that are very accommodating for the foot. The SAS shoes you probably are familiar with. They're wide and with a high toe box, and they can accommodate a lot of different problems. The MBT shoe is a shoe that has this concave or rocker bottom sole. And what does that do? Well, it allows you to walk without having to stress your foot. So if you have a lot of arthritis, or you just have plantar fasciitis, any kind of really painful condition, that can be improved by this shoe. It's kind of the concept we use like when we put somebody in a cast. If you were to see a cast, like a walking boot, they have a rocker bottom, and that again is to just propel the foot without a lot of energy and motion. Is there an SAS type shoe that's a little bit dressier, not so orthopedic looking? And yes, there are. Absolutely. Yeah, you want to have something nice, but you don't want to look like Herman Munster either, So I don't know if I believe all the things that they claim to do about improving your strength and your tone of your legs. They kind of go overboard on their advertising, but I do think for a painful foot, it can definitely help. And then running shoes. Running shoes is my most favorite shoe out of anything. If I can wear running shoes, that's the shoe I'm in, because a running shoe can provide stability or cushioning. They make it differently for different foot types. So if you have a flat foot, you need more stability or more motion control. If you have a high arch foot, you typically need more cushioning. That's why I really like running shoes. And you don't have to be a runner to enjoy a running shoes. Walkers can benefit from the running shoe. Orthotics and inserts. So personally, I think they're overprescribed. I think there's a role for them, especially like if you saw that, adult acquired flat foot person, there's no way they could wear over-the-counter insole. And they're great for chronic plantar fasciitis and so forth and other problems. I do think they're the best solution for long-term plantar fasciitis because the plantar fascia gets injured, it's stretched, and you get little tears in the fascia. That leads to thickening and scar tissue. And one of the things that helps heal it is that if it's supportive, and if you don't have that and your foot continues to stretch out, that fascia kind of re-tears itself, and it can be a really painful situation. But super feet are great. I wear them in my shoes. They don't work for everybody, but that's one of the first things I recommend for people for plantar fasciitis or foot pain. And it's just a good thing that you can put in your shoes to supplement the support. These are examples of other pads I use. The white pad on the left is a metatarsal pad, and that's great if you have a painful problem on the ball of your foot. You can put this behind the ball to off-weight that weight-bearing part of your foot. The one on the right is also great if you have pain in that joint, like from arthritis, or the sesamoid bones are often injured. Those are those bean-shaped bones that are under the ball of the foot. The thing on the right are heel lifts. I use those a lot for Achilles tendonitis, because if you have Achilles tendonitis, you want to elevate the heel, because the Achilles tendon is the biggest tendon in your body. You're using it with every step. You can't rest it if you're going to walk and live your life. So you have to do things like heel lifts and appropriate shoes to calm it down. Cartilage replacement. So we don't really have artificial cartilage yet to inject into our joints. It doesn't really work that great yet. So there is a procedure called the Oates procedure, and basically you're transplanting good cartilage into where the bad cartilage wasn't there. And it works pretty well in the ankle and in the metatarsal heads. The average time to heal is 3 to 6 months, and the initial results are fairly promising. This is kind of a schematic of what's done, again, in the ankle bone and in the first MPJ, or the primary places that it's used. This is kind of a schematic what they do. The cartilage is eroded in the first slide. You take a plug of that eroded cartilage, you remove it, you harvest some good cartilage from another part of the foot or ankle, and then you insert that plug into the area that the cartilage was eroded. And again, the initial results are fairly good. It takes about 3 to 6 months for complete healing. They've been doing it in the knee as well for years, and we're just kind of transferring that technology into the foot and ankle. Do supplements help? Again, glucosamine and chondroitin sulfate, these are two natural occurring substances that's found in cartilage, and they are recommended a lot for arthritis. Do they really work? Well, the Gates study showed that people that had severe arthritic pain in the knee, it did prove that it was effective. About 80% of people improved. Wasn't that effective for people that have had mild arthritic pain? Now, does that translate into the foot? We don't really know. But for me, if I had to take a supplement and it's it's fairly safe. There's some GI upset with it, but other than that, I would probably recommend it if you had severe arthritis. As a preventative thing, what kind of exercise you can do for your feet? Basically, you can walk in the sand. Sand walking is excellent for that. It builds up the intrinsic muscles of your foot, those small muscles that if they atrophy, they can lead to all these deformities. And I find that, like I say, I see a lot of foot pain in the summer months when people wear a lot of sandals or backless shoes or flip-flops. Those are very popular, especially with kids. I see so much foot pain from that because the shoe is not supportive enough. But I do think that our feet have actually gotten weaker because our shoes are better, and I do think that we don't do enough kind of foot strengthening exercises that we should, so I do think those exercises I recommended is helpful. Also, yoga, which is done barefoot, is definitely helpful for that. Other things that I tell people to do are try to pick up marbles with their toes or pencils, or you can grab a towel with your toes. Other things that you can get are these big rubber bands called TheraBands, and you can put them around your foot, and you can do window washing type exercises, left, right, up, down. That helps the ankle muscles. That's very common after an ankle sprain. Those are probably some of the best things I would recommend. Thank you.